I'm presenting here the story of a 6-year-old female who came to us with poor appetite, with nausea, fatigability, progressive abdominal distension. These symptoms were there for 4 weeks. She was taking medicine from nearby practitioner. Those are multivitamin and calciums only. In the 5th week of illness, she developed 2 episodes of cola-colored urine that were painless. A day later, parents noticed yellowish discoloration of eyes and decreased frequency of urine. There was no history of any documented fever. There was no diarrhea, abdominal pain and vomiting, no skin lesions, joint pain, joint swelling, no dysuria, pustules, no significant drug history was there, no bleeding from any other side, no seizure, alteration in sensorium or any CNS symptoms. So
the first question, and I'm going to ask Professor Thapa, the differential diagnosis based on this history, sir.
Please go to the first slide.
Back to the... Yeah.
Now, if you look at this very patient, 10 years old, she is having 2 episodes of, 2 distinct episodes in her 5 weeks of illness. The first one is of 4 weeks duration, where look at the loss of appetite, nausea, fatigability, progressive abdominal distension. Now, the 3 symptoms speaks of at least the abdominal distension, loss of appetite, fatigability. That means something related to liver. Then 4 weeks later, she gets something from the local practitioner. That means some drugs might have been introduced. Go to the next. Now 5th week, that means week later, she is getting two episodes of cola-colored urine, which was painless, and parents noticed jaundice in the eyes. And there was decrease in urine output. Now, thereby indicating that this child was suffering from some sort of a chronic problem, possibly chronic liver disease. And after 4 weeks, she gets another episode, and there is a history of some drug ingestion and so on and so forth, and then followed by cola-colored urine and jaundice and so on. So, thereby, this means that this child had first possibly some illness which was of 4 weeks duration, maybe earlier even, and then followed by cola-colored urine and jaundice, thereby indicating that there possibly is a setting for chronic liver disease with acute insult coming in. Now, question arises what it could be. Now, chronic liver disease, if you believe, we know that chronic liver disease like Wilson disease, because today we are talking about Wilson, that's why possibly that I am thinking as a first possibility. But if this would have been a different kind of scenario, I would have thought of something else. So Wilson disease with, something intervened. Maybe drugs have done trick, and that's why patient had IV hemolysis and cola-colored urine. So possibly it could be Wilson itself, or maybe some drugs have done the trick in a setting like this, and therefore one of the possibility of Wilson will stay on. And number 2 possibility, in a setting of again Wilson underlying or maybe any other chronic liver disease, we know in our setup G6PD deficiency is something which is around 5%, and therefore any stress situation can lead on to hemolysis, RBC break, and therefore they present with this type of scenario. In fact, this is the commonest scenario what we see in our institute, that acute viral hepatitis type of illness and IV hemolysis, cola-colored urine, and renal shutdown and so on. So I will think of course, Wilson as one of the possibility, and number 2, viral hepatitis with the IV hemolysis. Yes.
Well, in terms of the drugs, if we were to specify, the child just had multivitamins and calcium. So I don't think we would have any drugs there.
So drugs may not be
but
the culprit.
Could I just ask, the child did not have any fever, so hepatitis A and G6PD
may not
deficiency.
Be. All patients may not have fever, yes.
Right.
Yes.
Any other differentials? Could it be autoimmune hepatitis?
No,
something that 4 weeks history maybe. At this point in
autoimmune
time,
hemolytic anemia, yes, that can happen, but whether we like to have a cola-colored urine at that situation, I have not seen, but autoimmune hemolysis.
Theoretically, yes. Move on.
Past history was not significant. Family history was also not contributory. Dietary history was adequate prior to illness. She was admitted in nearby hospital and referred to us for further evaluation. On examination, her vitals were grossly normal. There was pallor were present, icterus was present, there was mild periorbital puffiness. Per abdomen wise, there was liver was 2 centimeter below costal margin and liver span was 10 centimeters. It was firm with sharp margins. Spleen was 2 centimeters below costal margin. It was firm in consistency and there was free fluid. Rest of the systemic examination was normal.
Just go back to the previous slide, if you don't mind. Our anthropometry was 25 versus 128. But this is not a, this was affected in fact. Tell you. Yes, go next.
Okay, so I'm going to pose this to Srinivas. Srinivas, based on the of the history and the physical findings, what would come to your mind now?
No, just go back. Yeah, so now we have the extra clinical finding that the child definitely has pallor and icterus. So going along with the cola colored urine, there is something obviously, something either like a gross hematuria or a hemoglobinuria that is going on. Periorbital puffiness indicates low albumin levels in association with a little bit of generalized free fluid in the abdomen, a liver and a spleen. Liver, which is especially firm, indicating a very chronic underlying liver disease that is going on with sharp margins. Splenomegaly indicating possible portal hypertension, and the presence of ascites indicates that this child has got decompensated liver disease. Probably cirrhosis with portal hypertension is something that should be high on our and this presentation usually should make us suspect acute on chronic liver disease. So an acute decompensation of an underlying chronic liver disease is what I would suspect. So still high on the cards would be possibility of a Wilson's, because this form of a hemoglobinuria presentation is not common with other diseases. But we would have other differentials in mind. You would secondarily also keep other things like autoimmune or even simple viral hepatitis as possibilities. You can sometimes have acute viral hepatitis presenting with a prodrome, have an underlying associated undiscovered hereditary spherocytosis or G6PD, and they can also present with hemolysis, though hemoglobinuria is uncommon.
So, Srinivas, you mentioned here that the fact that there is some free fluid makes you believe that there is decompensation of the chronic liver disease this child might be having. Would you want to just comment on that, especially for the trainees, in the light of all the papers that have been published from Chandigarh and Lucknow, about the fact that Indian kids, a substantial proportion of the kids we see are malnourished, their nutrition is borderline, they have an illness, and that can actually produce, their albumin going down. It's an acute phase reactant. So would you, for the benefit of the postgraduates, actually be brave enough to say there is decompensation of chronic liver disease based on finding some free fluids, or would you just wait and see, maybe as the child recovers from the acute insult, that goes away?
Okay, so if you just had a little bit of pedal edema, which in the process of, let's say, about 5 weeks to 6 weeks, there is low albumin levels which can go down if there is a child who is extremely malnourished, and then the child has a very severe liver disease. Low albumin levels and maybe a mild edema would be okay, but in somebody who has a firm liver, coarse margins, splenomegaly, ascites and pedal edema, I don't think I would attribute that to just nutritional.
Great. Good point. Any other comments from the house, and then I'll ask Dr. Thapa to comment. Ujjal, no comments from you. We've been in business for 7 minutes. Come on, please. We need to be listening to you and your input.
No, I think what Anupam, you were hinting at, that we have described in acute viral hepatitis.
No, I'm just...
This child had a unusual kind of symptom. First 4 weeks, non-specific symptoms. Right. If you assume them to be a prodromal symptom, you don't expect prodromal symptom to persist for 4 weeks, then develop jaundice in acute viral hepatitis. Right. So clearly this child's symptoms started with IV hemolysis. And then there is a jaundice and decompensation. It is clearly going towards Wilson disease.
Right. Thank you. Thank you so much for highlighting that. Professor Thapa.
Yeah, I think in this patient, if you look at the anthropometry, weight of 25 with ascites with organomegaly, then height of 128 centimeters. So it is equivalent to somewhere 7 or 8 years or so. So I think this patient was harboring, already malnutrition. Now we have to look into the cause for that, because this disease is of just 1 month duration only here in this patient, which cannot explain this much of abdominal anthropometry. So I think we have to keep in mind, possibly I'd like to comment in the end, right. Not now.
Over to you, Harshad. How would you like to investigate this child?
I mentioned it in my talk. This child is still conscious
Yeah.
the child.
Very well.
And we know very well that 1/3 of patients who present with what is called acute liver failure in children have normal consciousness, and 2/3 lose their consciousness at some point. So this is a window of opportunity. So as soon as the patient comes, send for serum ceruloplasmin, 24 hours urine copper, and CBC including reticulocyte count. But take that opportunity on day one to straight away send the child to an ophthalmologist and get a KF ring. If you have a KF ring, you can forever wait for the other reports to come, but you already made a diagnosis.
So you want to share what you found?
Here are the reports. HB was 8.3, TLC was 13,100, peripheral smear shows few cystocytes and fragmented RBCs, retic count was 7% corrected, DCT was negative, urine routine microscopy there was positive dipstick test for hemoglobin, though there was no RBC cast on urine routine microscopy. Total bilirubin was 19.6 with a direct component of 10.2. And her AST and ALT were respectively 670 and 214. GGT was 42, ALP was 47. PT, this INR was 3.7. And urea creatinine was also slightly elevated. It was 54 and 1.1. USG abdomen showed coarse liver, spleen, enlarged spleen, and mild ascites. On further investigation, our viral markers were negative. Ceruloplasmin was 8 milligram per deciliter. 24-hour urinary copper was 413 microgram over 24 hour, and KF ring were positive. KF ring was positive.
So I'm going to ask Professor Dhiman, and I'd really like you to comment, especially, we keep hearing about some of the adult data about this ratio of AST versus ALT, this whole alk-phos, bilirubin, and, it's kind of conflicting, and, so really, based on this, would you say definitely this is Wilson's disease, and just sort of highlight, because there are a lot of pediatric trainees who are not very familiar with
Can we go
some
back?
of that.
Yeah. Let me start from here. I think the three cardinal, I would say, the investigations: ceruloplasmin, single digit, 24-hour copper, more than 100, it is 400 microgram, and KF positive. I think there is no doubt that we are dealing with a Wilson's disease patient. And other associated etiology in the form of viral hepatitis is also negative. And we initially thought of the autoimmune, there is nothing. Can we go back one more? Yes, the bilirubin is very high, and AST is 670, disproportionately increase in relation to the ALT, which is 214, and maybe some of the component of the hemolysis also here. Platelets low, indicating cirrhosis most likely. Retics indicating the hemolysis. And DCT is negative, Coombs negative, hemolytic anemia. So that is the one thing, there is no doubt as far as the Wilson is concerned. Even if you see the another score that has been developed in the West also, Leipzig score. Leipzig is a place in the Germany, and you can see over here. Have you calculated how much it is?
Yeah, it is coming 7, sir.
7. It is coming 7. And anything which is more than 4. Anyway, it is not required here because we have all the things, but now it is also favoring that it is the Wilson's disease. The only issue is that this patient is a decompensated patient. That is the most important thing. What we have to think next in terms of the treatment, whether you have to chelate him or you have to transplant him. That is the most important thing. If somebody who is having the decompensated to that extent, although Harshad has commented upon the alteration in the sensorium, not yet, and it could be a window period kind of a thing. And I would say that it's a decompensated, we have to be very careful and look for the liver transplantation in this patient.
Dr. Dhiman, if I were to ask you, this is easy because, the KF ring, this is like, this is as easy as it can get. But, we don't always get this situation. So you get a ceruloplasmin of 12, the KF ring's not present. And, sometimes you get a urinary copper that's not very high. So in that situation, what's the words of wisdom you'd like to share in terms of, say, is this moving in the direction of Wilson's?
Anyway, that from the very beginning that we from the clinical, we thought of the Wilson, because any chronic liver disease or the cirrhosis of liver presenting with the hemolysis, you have to think whether it is associated with the underlying liver disease or it is unassociated. Unassociated J6PD, so many things also. But if it is associated, the Wilson's comes top of our mind. I think you cannot ignore in this group of these patients. And that will always remain, even if you said the ceruloplasmin, acute phase reactant, it could be normal or it could be the borderline also. And second, you said the urine also. Urine, I would say that in children also, even if you see the EASL guideline, for the adult they say 1.6 micromole, that comes to the 100 microgram. But if you say that it is 0.6 only, that has the
40.
almost the same.
Yeah.
So even it is the raised urinary copper, I will take in favor of the Wilson's in that situation. And KF ring, if it is negative, it could be because it's a liver disease, hepatic disease, it is not a neurological that you will find it. I think in that situation, I'll go ahead, I am a little bit more invasive kind of person, I'll go for the TGLB.
So would you, and Harshit, I'd like you to comment on that. Would you do a penicillamine challenge in a setting of an acute liver failure when it's not very high? Not for this child. No, I mean, this child is easy.
No, I review.
Yeah.
No.
Just-
I said it, not this child.
We,
No, I'm just saying sometimes it's not very high. You're in a dilemma. So, I mean,
So
Dr.
You are
Dhiman's
you are saying
talked about.
penicillin in favor of the urinary copper.
Yeah, I mean, would you do a penicillamine
You
challenge?
have already said that the copper is
No,
raised.
not for this child, Dr. Dhiman. I'm just saying, supposing it's not so high.
we reviewed this a couple of hours ago.
Oh, okay.
And we said that the story of PCT has been laid to rest.
Okay, good.
Yeah, it is not.
So move on.
So, acute liver failure in Wilson's disease, there are few markers that have been discussed. There is modest rise in serum aminotransferases. They are normal to markedly subnormal serum alkaline phosphatase, AST-ALT ratio of more than 2.2 and alkaline phosphatase bilirubin ratio to less than 4, comb-negative hemolytic anemia and hemolysis and rapid progression to renal failure.
Just stop here. I'm going to ask Ashish, do you see this? I mean, this ALT, AST, ALT and ALP bilirubin, this is really adult data. Okay, sorry.
Based on a very
Small cohort, yeah.
Long time back. In fact, you will get this scenario in some of the people. Here also, if you observe,
We did.
the AST levels are very high.
Very high, right.
2 and alpha is just 24.
Yes.
I'm not saying that you take it as a criteria.
Right.
But we have seen a couple of children who have this kind of phenomenon, had
Right.
acute liver failure. One of them turned the corner just on therapy.
Right,
Yeah.
right.
Yeah.
Therefore, in Wilson disease, you should not actually go for transplantation quickly.
Sure.
Unless the score is quickly.
Absolutely.
Here is a patient where you can actually try a good medical therapy and see the response over a
Right,
period of time.
right. Absolutely.
Transplantation option.
Yeah,
No,
I do
see,
agree with you, but I think
we are just into the presentation. So the child presented, we did this. Now this is what happened to the child. So
On day 3 of admission, she developed altered sensorium, she was drowsy and there was hyperreflexia suggestive of grade 2 encephalopathy. So now,
this we've already done, so we move forward. So this is what we really have.
so prognostication markers.
I mean,
have been
Professor Dhiman had mentioned. Sorry, Bolo Sima?
Just for the sake of the fact that, just go back one slide, just for the sake of correcting the acute liver failure concept here.
Yeah. Please give the definition and explain that. But we are doing this for the ease of simplicity.
This is not even ACLF to me because I'll tell you why. I'm not even saying anything else. I'm just for the sake of the students. This child was already decompensating when he had jaundice. So this was, the insult came later and the decompensation was earlier. So that is why this is not ACLF.
Sure. So we have this situation, and Professor Dhiman had kind of mentioned earlier in terms of prognostication. So now we have a child who's become encephalopathic.
yeah, I think dictum is that the Wilson's who's become encephalopathic, the survival rate itself is very, very poor.
Harshad, you want to
Mortality
comment
is
about
more
the
than
Nazar
90.
and the new Wilsons
And
the
then we
relevance?
have the scoring system also, Nazar, and the modified also, that is by the Dr. Dhawan also. He has included two more, that is WBC and the albumin. I think you have already encircled also, and the score is the 16, it is much higher than the 11. I think this
16.
patient should be
More
subjected
than
for the
11.
liver transplantation.
Yeah.
Sorry, Seema?
There should,
Just after this, I'm speaking on the same thing.
Oh, okay. All right. So we shall not talk about it too much, but I want to ask Harshad, because Harshad, you've really done all the statistics. Did you find any differences in India? And I'm quoting your paper next. I mean, we're quoting your paper.
No, I think there are a lot. We require these severity scores for liver diseases, and we can't have one severity score for each liver disease. You don't know. So basically, what we have is a MELD score, PELD score, which can be applied to all liver diseases. So, and I know I didn't have time in the morning. MELD score has a better calibration. So when I say calibration, it means if there is a patient with Wilson's disease,